begin endocrinology.
Yes.
The two glands we will discuss today, one thyroid and other pancreas. The drugs related with thyroid. If the thyroid hormone T3, T4 high, or it's a hyperthyroidism, hyperthyroidism. And if T3, T4 level low, it's hypothyroidism. Okay. The remaining thing, what are the causes about hyper and hypo? It's everything present in pathology, like Graves' disease, the Graves' disease for hyperthyroidism, another Hashimoto, Hashimoto thyroiditis, another iodine deficiency, iodine deficiency goiter. So most common cause for hyperthyroidism, the most common cause, okay, for hyper. And Hashimoto thyroiditis is also common autoimmune is for hypothyroidism. If the patient having hyperthyroidism, okay, then we need to use drugs to block the production, to block the activation of this hormone. For simplicity, first we see the case of hypo. Okay, this hypothyroidism due to Hashimoto thyroiditis or iodine deficiency goiter, iodine deficiency goiter, it also lead to hypothyroidism. If the patient have hypothyroidism, so in this case, decrease level of T3 and T3 and T4, decrease level of T3 and T4. So for this purpose, so we can use a simple drug, levothyroxine. Levothyroxine. So it's a thyroid hormone, thyroxine. Okay, this one, levo in the form of levothyroxine. So this drug from outside we use for if the patient diagnosed with hypo. For treatment of hypothyroidism, we use levothyroxine. Okay, levothyroxine. If the patient having hypothyroidism, okay, this drug we only use for hypothyroidism. If the patient have the disease, like the most common cause for hyper is the Graves' disease. Yeah, most common cause is the Graves' disease. To understand the mechanism of drug for hyperthyroidism, first we focus a little bit about physiology of thyroid hormone, how it produces the thyroid follicle. It's an apical side, it's a basal side, it's apical side, the thyroid follicular cells. Okay, iodine enter into the cell. This iodine change to iodide, the simple organic iodine here is organic. This iodine in the form charged particle in the blood later change to iodide ion. Okay, the pump here. Here is iodide pump, and then this iodine. Here we need one enzyme. Enzyme number 1, iodide peroxidase. Iodide, which enzyme? Iodide peroxidase. Okay. So already production of thyroglobulin here, rough endoplasmic reticulum. Rough endoplasmic reticulum produce protein, and then Golgi apparatus doing the packing here. Production of which protein? Production of thyroglobulin. Which protein? Thyroglobulin. Then this protein is going outside. This protein is going outside, and it's a follicle lumen. It's a one follicle, one cell here, one here, one here, one here, one here, like this. It's just a cell number 1, okay? Cell number 2, cell number 3, 4, 5, like this. So this central part of this is one follicle. This central part known as colloid. This central part of follicle known as colloid. So after production of thyroglobulin, this thyroglobulin exocytosis here, and now this is thyroglobulin here. Okay. So this is how we produce thyroglobulin. Thyroglobulin we produce by using amino acid tyrosine. Tyrosine enter here. Then this tyrosine used by rough endoplasmic reticulum change to protein thyroglobulin. Then iodine, after peroxidation, this iodine transfer here, okay? Transfer here. Now this iodine attach with this protein. This iodine attach with this protein. This iodine attach here, iodine attach here, iodine attach here, iodine attach here, like this, okay? So now the enzyme we need here doing this. You can see here the iodine come from here, and thyroglobulin protein come from here, both in colloid. So here we need enzyme here, thyroid peroxidase, another enzyme. Thyroid peroxidase. This is your enzyme, another enzyme, the second enzyme. Okay. After that, what happened when this iodination done? This protein again taken back, okay? Endocytosis. First here, this we done. Exocytosis, okay? Now, after addition of iodine, we do endocytosis. Endocytosis of this thyroglobulin in the vesicle, okay? Inside the vesicle. This is thyroglobulin. This thyroglobulin is not simple thyroglobulin. It's also attached iodine with iodine. It's an iodinated thyroglobulin. Iodinated thyroglobulin. Clear? Now this thyroglobulin, here we use here another enzyme for breakdown, lysosome. Okay, this we know after phagocytosis, endocytosis breakdown done by lysosomal enzyme. So breakdown for this from the cell, T3 coming out and T4 coming out. T3 and T4. Okay, so which one is released more? 95% T4 and the remaining 5% T3. Done? The remaining thing inside the cell, the left behind, number 1, DIT and MIT. DIT and D for di, M for mono. Iodo, tyrosine. Diiodo, tyrosine. These things not going out, okay? DIT, MIT stay inside the cell. Enzyme number 3, number 1 enzyme here, iodide peroxidase. Number 2 enzyme here, thyroid peroxidase, okay? Enzyme number 3 inside the follicle. This enzyme known as deiodinase. Deiodinase. This deiodinase present where? Inside the follicle. Inside the follicle. So the name for this deiodinase, follicular deiodinase. This follicular deiodinase doing what? Separate the iodine from the tyrosine. Okay. This iodine again enter to colloid. This tyrosine after production to Tg, okay, enter to colloid. So, so this enzyme for what? For recycling. This enzyme for recycle. Okay, now come back to T3T4. And this T3T4, you can see mostly 95% we have T4 and 5% we have T3. So which one is active? T3 active. Which one is inactive? Which one is inactive? T4 is inactive. Little bit wait. I want to charge laptop. Okay, wait little. We were discussing about normal physiological mechanism of production and release of thyroid. Okay. Now this one T3 active and T4 inactive. 95% this one and 5% this T3. So in the tissue, before entry to cell, is your tissue. Okay. In the tissue before entry to cells, in the peripheral tissue, so mostly we having what? T4. This T4 change to T3. T4 change to T3. So close to the tissue, inside the tissue, we having another enzyme here in the tissue. So this known as also deiodinase. It's also deiodinase. This deiodinase, also known as tissue deiodinase or peripheral deiodinase. This deiodinase is known as peripheral deiodinase. Okay. Convert T4 to T3. Now this hormone is more now 95%. Okay. Now it's changed to T3. It's become active. Then doing its duty into the cell. So this is your enzyme number 4. Understand? 3 enzymes present inside the follicle: iodide peroxidase 1, thyroid peroxidase 2, follicular deiodinase 3, peripheral deiodinase 4. We have 4 enzymes. Okay. For release and activation of thyroid hormone, we use 4 enzymes. If the person having the issue like hyperthyroidism, so we can use drug to block these enzymes. Here we having the group here. Number 1, carbimazole and methimazole. The 2 drug group here. Number 1, methimazole. Carbimazole, methimazole, carbimazole. Azole family, okay. And another propyl thiouracil. Propyl thiouracil. Short form P propyl thio T uracil U PTU. Okay. So this is drug number 3. Methimazole, carbimazole, propyl thiouracil. Methimazole and carbimazole, they directly work inside the follicle. Methimazole and carbimazole, they enter the follicle and block this, okay? Block what is this enzyme? Thyroid peroxidase. They block iodide peroxidase, understand? Methimazole and carbimazole. They block thyroid peroxidase and iodide peroxidase, the two enzymes, yeah? One for conversion of iodide to iodine, another for conversion of for the main production of thyroid hormone, okay? For iodination of thyroglobulin, thyroid peroxidase. So methimazole, carbimazole, these two drugs, they block what? They block these two enzymes, understand? And what's the action of PTU? Propyl thiouracil. This propyl thiouracil enter here and block this. Enter follicle cell also block this. And this propyl thiouracil also block this enzyme. Oh, try to understand here what the difference between methimazole, carbimazole, and propyl thiouracil. So which drug you can think more better? Which drug is more better? Methimazole, carbimazole, or propyl thiouracil?
PTU.
More stronger to block. PTU is more stronger, okay? PTU is more stronger. Why? Because PTU, methimazole, carbimazole, to azole, okay? They just block thyroid peroxidase, iodide peroxidase. It means they can block production, yeah? If no production, also release, also decrease. So they can block the production. How about the PTU? PTU, they block the production plus the important point here, they also block the activation. The hormone is already outside, already released from the gland, yeah? Their activation inside the tissue, they also block this step. That's why if just like, for example, one patient come to you having hyperthyroidism, hyper hyperthyroidism, just hyperthyroidism, okay? Have hyperthyroidism, I can use azole, methimazole and carbimazole. Methimazole and carbimazole. Understand? May you listen another time. Thyrotoxicosis. Thyrotoxicosis. What the meaning of this? What the difference from this? Hyperthyroidism is just a mild case, okay? It's just a mild case. Little hormone is high. You can use methimazole, carbimazole, okay, no problem. Understand? So if you have thyrotoxicosis, another terminology you already done in physiology, thyroid storm, very high level of thyroid hormone outside, yeah, very high level. At that time, for thyrotoxicosis and thyroid storm, not go for just this, okay? If you have little thyroid hormone production increase, okay, you can go and block the thyroid peroxidase and iodide peroxidase. But if your body is totally filled with thyroid hormone, very high level of thyroid hormone, very high level of, it's a severe case now, T3, T4, T3, T4 already very high in the blood plasma. Here T3, T4 just a little high, understand? Just a little high. Here very high level of T3, T4. That time your preferable drug, thyrotoxicosis or thyroid storm. Not choose the answer azole, okay? Then you just go for PTU. Understand? Clear or not this concept?
Yes, sir.
So if you have very high level of thyroid hormone in the body, that time the drug of choice is not methimazole, carbimazole. The drug of choice is PTU. Understand? Propyl thiouracil. Propyl thiouracil is a drug of choice for thyroid storm, for thyrotoxicosis. Okay. If you remember what happened in thyroid hyperthyroidism, heart rate very high, blood pressure very high, because sympathetic system is up now. Thyroid hormone stimulates the sympathetic system. Okay, so along with, if the patient comes to you with having like the issue here, thyrotoxicosis and thyroid storm, and you can combine PTU also along with beta blocker. If you remember beta blocker, which beta blocker is preferable for thyrotoxicosis or hyperthyroidism? Try to recall from the previous lectures. Which beta blocker? Okay, I give you hint. Atenolol, propanolol, bisoprolol, metoprolol. Choose one. There's only one beta blocker. We can select any. You have the heart rate problem. Okay. You have very high heart rate. I can use beta 1 blocker, metoprolol, bisoprolol. Yeah. You can use any beta blocker, but you use selectively one drug there. Try to recall the name of that drug. Atenolol, propanolol, metoprolol, bisoprolol. Which one you prefer for here? Very important beta blocker. The first
Propanolol.
beta blocker. For hyperthyroidism, I must use propanolol. Understand? I must use propanolol. What is the benefit of propanolol here? What is the benefit of propanolol here? Because propanolol is not just a machine, just a beta blocker. It help you decrease the heart rate. It help to decrease the blood pressure, decrease heart rate, control sympathetic system. Okay, we know these are the beta blocker. This is a beta blocker. The extra benefit, I just write a one sentence. Act like PTU. What's the meaning of this act like PTU? Act like PTU in tissue. It's the meaning here. Act like PTU in tissue. This also not allow this conversion. Understand? This propanolol, why you not use metoprolol, bisoprolol, atenolol, pindolol, acebutolol, lot of beta blockers there. But why you just select propanolol? Because propanolol also decrease the activation of thyroid hormone. So in one thing, you need to control the blood pressure and heart rate high. Yeah, you can choose any beta blocker. You can choose any beta blocker. But why here? The important thing about the propanolol. Why you select propanolol? There must be some reason. Okay, propanolol because it's not just a beta blocker here. It also help PTU. Understand? It also help propyl thyroid cell to block the activation of the hormone. Understand? To block activation of hormone. Propanolol doing what? Propanolol, PTU, this T4 changed to T3. Which enzyme we use? D-iodinase. Yeah? D-iodinase enzyme. That's a peripheral deiodinase. Okay? This T4 changed to T3. This T4 can change to R reverse T3. The reverse T3 is still inactive, is not active. Okay, the beta blocker propanolol doing what? Propanolol not allowed to form this. Yeah, this one is very active. Propanolol beta blocker, what done this is T4 because we block this pathway. Then this T4 try to change to reverse T3. Okay, reverse T3. This reverse T3 is inactive. Reverse T3 is inactive. Understand? Reverse T3 is inactive. So it's mean already in thyroid storm and in thyrotoxicosis, you have already released lot of thyroid hormone in the blood. Yeah. Now we just can't rely. You just block the thyroid production and release from the follicle. You must block the activation also here. Okay. Then you prefer PTU and beta blocker along with PTU. Beta blocker along with PTU. Clear or not? So we use
Yes,
in
sir.
thyrotoxicosis, we use beta blocker plus PTU. Okay, now come to the another point. What to think about the pregnancy? This you already know. The Graves disease is a very common disease. Yeah, Graves disease, very high level of T3 and T4 hyperthyroidism case, mostly female because it's autoimmune disease. Autoimmune disease more common in female. If this in female, then now must think about pregnancy. So if the female having pregnancy also T3 T4 high. Okay. The first trimester. The first trimester is mean the first 3 months. Yeah. First trimester mean first 3 months. During first 3 months, I can't use azole. Must keep in mind. Never give azole to mother. Okay. Never give azole to mother because it's azole to mother. If you use in first trimester azole, that's not safe. This azole, carbimazole, methimazole. Carbimazole, methimazole, they cross placenta. And the first 3 months very important for the baby organ formation. Yeah, baby organ formation very important. Understand or not? The first 3 months very important for organ formation. Yeah, the full baby formation. The first 3 months very important. So for first 3 months, I can't use azole, methimazole, carbimazole. Methimazole, carbimazole, these two drugs, methimazole and carbimazole. These two drugs, can you use in pregnancy? I can't use in pregnancy, okay? Okay. How about the duration? Especially first 3 months, okay? The mother have, why you want to use this drug here? Listen carefully. You have hyperthyroidism. If mother have hyperthyroidism, now mother, of course, mother hypertensive. Hypertension is not good in pregnancy. It can lead to eclampsia, preeclampsia. Okay, so it's not good for the pregnant lady. Understand? The blood pressure must be in control. Hyperthyroid. I must treat hyperthyroidism or hypothyroidism. Understand? I must treat hyperthyroidism or hypothyroidism if in case of pregnancy, because thyroid hormone is also important for brain maturation. So you must control the thyroid level. Understand? Why you need thyroid control in the mother? Because thyroid hormone we need for brain maturation. Thyroid hormone is important. Understand? Thyroid hormone for brain maturation is very important. Thyroid hormone. Okay, thyroid hormone. If hyperthyroidism case here in mother pregnancy also, so I can't use azole. How about the duration? First trimester I can't use. If the in the scenario they write the second trimester, okay, they write second trimester start from the fourth month, fifth month, sixth month. This is second one. So you can use both of them. Listen carefully. You can use methimazole. Sometimes they write the you not just focus on the word pregnancy. Okay, also see how about the time they written. If they are if they're saying that pregnancy already 4 month 5 month, okay, can you use methimazole, carbimazole? Yes, I can use methimazole, carbimazole. This point is important, okay? Do you understand or not? Within first trimester you can't use methimazole, carbimazole for case of hyperthyroidism, okay? during first trimester during first trimester, so what you use? PTU. PTU